Access to healthcare remains a major social challenge in Malaysia today. While infrastructure exists, the access is not equal. Rural communities travel far for basic care, public clinics are overcrowded, and private services, although they are faster, are often unaffordable for low-income groups. These gaps lead to delayed treatment, poorer health outcomes, and a widening inequality gap. To understand why, we need to look at how Malaysia's healthcare system is structured. Malaysia's healthcare system is divided into two tiers: subsidized public care and a faster private sector. But access between them is unequal. Public clinics face long waiting times, on average around 54 minutes, while rural areas have about 3 times fewer doctors than urban areas. At the same time, private clinics outnumber public ones by around 5.6 to 1, and patients who can afford private care receive treatment up to 7 times faster. But this speed comes at a cost, making it inaccessible to many rural and lower income communities. As a result, patient satisfaction in public facilities remain relatively low at around 45%. Overall, this highlights a clear gap in both affordability and access. Looking deeper, the issue is not a lack of healthcare facilities, but on how unevenly the resources are distributed and how demand is managed. 4 key factors drive this: geographic inequality, system overload, doctor shortages, and operational inefficiency. The most affected groups are rural communities, B40 families, and the elderly. These are the groups that face the greatest barriers to access. At the same time, public healthcare providers are overwhelmed, while private clinics sometimes remain underutilized. Ultimately, this reflects a mismatch between where healthcare is available and where it is most needed, and addressing this benefits all stakeholders. To address this, we propose MediBridge, a digital healthcare platform that integrates teleconsultation, a triage chatbot, appointment booking, and clinic referrals. The platform uses WhatsApp as its main entry point, making it simple and accessible even in rural areas. This allows patients to access care faster, reduces congestion in public clinics, and keeps services affordable. Most importantly, it ensures that patients are directed to the right provider at the right time. By improving how patients connect to existing healthcare services, MediBridge closes the access gap without requiring new infrastructure. I will now pass this on to Sian-Chi to talk about the platform features.
Thank you, Chloe. Main features of our platform is online consultation, where patients in rural areas can consult healthcare professionals remotely via chat or video, reducing the need for long distance travel. Secondly, we have tried system where we have a chatbot to collect basic information from patients. Thirdly, we have an appointment booking where users can book consultation with partner clinics, ensuring better coordination and reduced waiting time. Fourthly, we have clinic and hospital referral system where the platform identifies and direct user to the nearest available healthcare providers. Lastly, users can access a timetable where they are able to book specific consultation timing with specific doctors. And moving on to the key revenue stream and cost structure. In our business model, we have a few main sources of income, that being the commission fee of 20% from online consultations, where we estimated 20 consultations per day at the start of our business and expect a 50% growth in every subsequent year. And we have clinic memberships of RM250 per clinic, with estimation of 10 clinics at the start of the business, with expected 50% growth for every subsequent year as well. Independent memberships of RM100 will be charged for individual doctors, where we expect with a start of 20 independent doctors and a growth of 25%. And lastly, a 20% commission fee for every successful sale of medication through patients we refer to our collaborated clinic. Now, moving on to the cost structure, our most important cost includes the subsidized medication discount of 5% we provide to patients that visit our collaborated clinics to purchase our medicine. Our other costs also includes salary of staff. All these are considered a full-time staff, which we will be giving a bonus from year 3 onwards. To portray a real-world context, we also consider the founders of the website will be working on the website as well. We estimated 3 full-timers and 2 part-timers. The full-timers will also receive a bonus. This bonus will be based on profit growth of the business. Now, I'll be passing on to Chloe to continue on the implementation timeline.
Thank you, Sian-Chi. So our implementation roadmap is structured across 5 years to ensure gradual scaling and operational feasibility. Starting with Q1 of year 1, we focus on the foundational setup. This includes registering the company, hiring 2 operation staff, and establishing key partnerships with SSM, MMC, and the Ministry of Health, while onboarding our first 5 clinics and 10 doctors, alongside engaging a web developer vendor. Moving into Q2 to Q4 of year 1, we will officially launch the platform in Sabah and Sarawak. This includes teleconsultation services and monthly pop-up clinics in rural areas, supported by volunteer medical students and nurses from our partner clinics. By the end of year 1, we aim to reach 20 consultations per day, supported by 10 clinics and 20 doctors. In year 2 and 3, we expand into Kelantan and Kedah, scaling our operations to 45 consultations per day, with over 20 clinics and 30 doctors on the platform. This growth is supported by consistent increases in demand and capacity. Finally, in year 4 and 5, we scale into additional states, and by year 5, we achieve over 100 consultations per day, supported by a strong and expanded network of clinics and doctors nationwide. For our future plan, we're expecting to expand our business into the entire Malaysia. Overall, this phased rollout ensures controlled growth, efficient resource allocation, and long-term sustainability. And now I'll pass it on to Kayan.
Thank you, Chloe. I'll be talking about the impact assessment and metrics for measurement. There are 3 main social impacts that relate to the Sustainable Development Goals. The first SDG goal is SDG 10, which is reduce inequalities. People living in rural areas are able to receive the same same quality and quantity of healthcare services of those living in urban areas. The second SDG goal is SDG 3, which is good health and well-being. Providing healthcare consultations online can increase the medical access, which will enhance a person's healthcare and mental well-being. This in turn also leads to a better quality of life. The last SDG goal is SDG 9, which is industry, innovation, and infrastructure. Our platforms leverages digital innovation to modernize healthcare services. There are also several metrics to measure short-term and long-term outcomes. The first short-term metric is calculating the number of consultations. This measures the usage of the platform and initial adoption by patients. A reduction in unnecessary hospital visits shows how effective helping hospital overcrowding. Lastly, we can obtain the number of active clinic or doctor collaborations. This indicates the level of participation from healthcare providers, which affects service availability and scalability. For our long-term metrics, we can calculate the reduction in rural-urban consultation gap. This measures how well the platform is closing the disparity in healthcare access between rural and urban populations. The increase in rural healthcare access rate can also be used. This reflects improved availability and usage of healthcare services among rural communities over time. Finally, the difference from previous years of the number of collaborating clinics and doctors in percent. This tracks the growth rate of the healthcare network, showing how the platform expands its collaborations and coverage over time. I will now pass off the time to Caitlin for the risks and mitigations.
Now I'll identify potential risks our business might face in implementation stage. First is technical failures. So rural areas has unstable internet connectivity and there is high likelihood that during the consultation, the Wi-Fi may be down. What we can do for this is if a session cannot be completed, patient is not charged and is given a free follow-up in the next booking. Next is data privacy. So patient health data is highly sensitive. Breach of data can destroy patient's trust and also expose our business to legal liability. So what we can do is to ensure that we always comply with the Malaysia's Personal Data Protection Act, PDPA 2010. We also will conduct regular security audits. Next is a doctor liability and malpractice claims. So if a patient is misadvised and their condition worsens, doctors could potentially face legal action. What we can do is to ensure that before doctors and clinics join us, we will do a registration background check through the Malaysian Medicine Council, MMC. We also ensure that all doctors have professional indemnity insurance and we will clearly communicate to patients that online consultation is not a replacement for in-person emergency care. The fourth risk is a reluctance to join from clinics and doctors. So established doctors and clinics may view us as a threat to walk-in patient volume. What we can do is to position ourselves as a supplementary income rather than a replacement. So doctors can also serve rural patients they would never otherwise reach. Next is a misuse of chat system, which is patients may intentionally or unintentionally misrepresent their own symptoms. So we will make sure that our questionnaires are structured and symptom specific. Doctors during consultation must also escalate cases that seems inconsistent. Also make it clear in the terms and conditions that patients must provide accurate information. Otherwise, we are not liable for issues arising from misinterpretation. Lastly is the low digital literacy. Users in rural areas may be unfamiliar with online consultation. So what we can do is also provide voice note option within the chat for users who struggle with typing, provide a step-by-step guide to assist users to using our platform. And if users come to our pop-up, the staff there will teach them how to use our platform. We will also provide 3 language options in our platform, so that being English, Malay, and Chinese. So in conclusion, Malaysia does not lack healthcare overall. The issue is the inefficient distribution and system overload. We propose our platform as a solution because we want to improve the health outcomes of patients, reduce inequities, and strengthen health system and economies. Thank you for listening.